pneumonitis. Where in the lungs are the pulmonary nodules most likely to be located? Lung periphery. CT of his thorax. A. Solitary 2 cm endobronchial polypoidal mass that enhanced vividly in the late arterial phase. From which artery is the blood supply to this lesion most likely to be derived? Bronchial artery. 37 Following radiotherapy for thoracic Hodgkin's disease, a new anterior mediastinal cystic structure was identified on CT thorax of a young adult male. It was well defined and showed no aggressive features. Diagnosis. Thymic cyst. CT. A soft tissue mass with a feeding vessel from the thoracic aorta. Diagnosis. A bronchopulmonary sequestration. 2-day history of chest pain. Pyrexia and productive cough. Neutropenia. PA and lateral chest radiographs. A 4 cm round mass in the left lower lobe. What is the most likely causative organism? Streptococcus pneumoniae. Male returned from traveling abroad in South America. Repeat chest radiograph obtained a year later. Multiple punctate calcifications. Diagnosis. Histoplasmosis. HRCT. Are thin-walled cysts 5 mm in size and centralobular nodules with normal intervening lung. Most likely diagnosis? Langerhans cell histiocytosis, LCH. Interlobular septal thickening with nodular pattern and a right-sided pleural effusion. CT. Most likely diagnosis? Lymphangitis carcinomatosis. Chest radiograph. Lung. Metastases. Most likely underlying primary tumor? Testis. Calcified lung nodule on chest radiography. What pattern of calcification would make malignancy more likely? Multiple small foci of calcification. Legionnaire's disease. Diagnosis was considered. What finding in the workup would make a different diagnosis more likely? A prominent lymphadenopathy. What additional finding would be most suggestive of chronic rather than acute thromboembolic disease? Narrowing of the peripheral pulmonary vessels. Chest radiograph. Showed loss of the right heart border and a straight left heart border. What is the most likely diagnosis? A pectus excavatum. Bronchial dilatation. Male smoker. Chest radiograph hyperinflation and bibasal bullae formation with relative sparing of the upper zones. Diagnosis. DIR1 antitrypsin deficiency. Chest radiograph. There is a discrete mass arising behind the heart on the left. The lateral border is smooth and rounded. Medially, the mass obscures the lateral border of the descending thoracic aorta. No other abnormalities are visible. Most likely diagnosis? Schwannoma. Ventilation perfusion scan was arranged. What appearance would be most compatible with the diagnosis of pulmonary thromboembolism? A segmental perfusion defect much larger than an associated ventilation defect. B subsegmental matched ventilation/perfusion defect. Known hypersensitivity pneumonitis. Underwent HRCT. During the last part of the scan, a medical student asks you why the radiographer has scanned the patient prone on expiration. What is the most rational explanation? B. To accentuate differential lung attenuation caused by air trapping and obviate any gravitational, dependent, changes seen on the supine scan. Chest radiography. A mass in the superior mediastinum. The mass extended into the neck and there was slight deviation of the trachea to the left. What is the most likely cause? Thyroid enlargement. Endoscopic ultrasound. Showed a rounded, thin-walled, echopore cyst located anterior to the esophagus in a subcarinal location. Mucoid material was aspirated from the cyst. Most likely diagnosis? Bronchogenic cyst. Chest radiograph. The most likely diagnosis? Acute interstitial pneumonitis, I. 55. Chest radiograph showed bilateral patchy airspace opacification with air bronchograms sparing the costophrenic angles. HRCT showed consolidation and ground glass change, bronchial dilatation and architectural distortion, and subsequent lung biopsy demonstrated hyaline membrane formation. The most likely diagnosis? Acute interstitial pneumonitis, HIP, air bronchogram, consolidation, hyaline mem. 56. Known history of cardiac arrhythmias. HRCT. Septal thickening and diffuse ground glass changes in a largely symmetrical and predominantly basal distribution. The liver was also markedly more dense than the spleen. What is the most likely explanation for his dyspnea? B. Drug-induced pulmonary damage. 57. What imaging feature is most in keeping with pulmonary hemorrhage? Bilateral patchy segmental and lobar consolidation and ground glass change. 58. Newspaper editor. Had smoked 20 cigarettes a day for 45 years. Pulmonary function tests. Reduced FEVI and FEVI-FVC ratio, which did not improve with bronchodilator therapy. What are the most likely findings on CT? Centrilobular emphysema in a predominantly mid and upper zone distribution and bronchial wall thickening. 59. Known history of HIV infection. CD4 count was 90. Bronchoalveolar lavage. Pneumocystis carinii. What appearance would be likely on his chest radiograph? Bilateral perihilar consolidation and ground glass change. 60. When is it considered acceptable not to obtain written consent? A procedure where the patient's actions imply consent. 61. A patient with lower limb ischemia. When is thrombolysis most appropriate? Acute limb ischemia. 62. To assess suitability for EVAR, endovascular aortic repair. What would make EVAR unfavorable? Narrow iliac arteries, 8 mm. 63. An individual underwent a stent graft repair of an infrarenal aneurysm and was followed up with CT aortography the next day. A blush of contrast was seen within the aneurysm sac close to the origin of a small branch from the aorta. What is the next appropriate step in management? No immediate intervention follow-up but may be self-limiting. 64. The right heart border is prominent in a frontal chest radiograph on the lateral chest radiograph.